Welcome to today's Explainer. We're jumping right into a really fascinating piece of medical history and philosophy today. We're going to unpack Samuel Hahnemann's classical framework for clinical assessment. Specifically, we'll be looking at how practitioners are taught to navigate cases where the true underlying nature of an illness is actually hidden from plain sight. We're going to break down some of the denser theories from his Organon of Medicine into clear, totally approachable concepts. So picture this. You walk into a clinic and you've got this screaming, absolute agony in your right knee. To you, obviously, that is the entire problem, right? But to a classical homeopathic practitioner, this is the ultimate tip of the iceberg dilemma. How on earth do you treat an entire human being when they show up with just a single, overwhelmingly dominant complaint? According to this classical framework, if you just treat that visible tip, you're setting yourself up for some profound clinical errors.
Here's our quick roadmap for today. We'll cover the one-sided dilemma, uncovering the hidden totality, evaluating local diseases, the danger of suppression, and finally, red flags and referrals. All right, let's dive into section 1, the one-sided dilemma, and what happens when one symptom totally dominates the picture.
Hahnemann called this specific problem a one-sided disease, or einseitige Krankheit. It's essentially a condition where one or two main symptoms are just so incredibly overpowering that they act like a massive blinder to the clinician. That severe local pain or maybe a really intense visible skin lesion, it just screams for your attention, and in doing so, it completely obscures the rest of the patient's overall disease portrait.
But this raises a really critical question for any practitioner. Is the lack of other symptoms a real biological reality, or is it just a massive failure of the clinical interview? What the text calls true biological paucity is actually quite rare. That only happens when a deeply ingrained chronic state expresses itself in a highly localized structural way. What's way more common is apparent paucity. And this happens when the practitioner rushes the consultation, asks really narrow or leading questions, or honestly, just fails to look beneath the surface. The symptoms are there, they just haven't been uncovered yet.
Which brings us nicely to section 2, uncovering the hidden totality, where the practitioner essentially has to become a systemic detective. Okay, so you absolutely do not ignore that visible, screaming symptom. Instead, you use it as your starting anchor. You fully qualify it, like when exactly does it hurt, what makes it feel worse, but then you systematically probe outward into other clinical domains. And here is the kicker. You have to do this with totally open, neutral questions. You do not want to accidentally plant suggestions in the patient's mind. The goal here is to carefully reconstruct that hidden, whole-person totality. To pull this off, the classical methodology uses an investigative checklist of 7 clinical domains. The practitioner is going to ask about the chronological timeline of the illness. They'll dig into sleep architecture and dreams. They'll check thermoregulation. Does the patient generally run hot or cold? They look at appetite, basic physiological functions, the patient's mental and emotional state, and of course, past medical history. By neutrally sweeping through these 7 areas, a literal mountain of hidden data emerges. And that reveals the true nature of the illness, way beyond just a single knee pain or a rash.
Now, once treatment actually begins based on all this hidden data, the case is inevitably going to shift. New symptoms might pop out of hiding. When that happens, the clinician has to impartially evaluate 4 key metrics. What is the exact trajectory of that dominant symptom? Are these new features reliable, old dormant symptoms waking up, or just transient background noise? Has the objective disease status actually changed? And crucially, are there any red flags? This reassessment is absolutely vital because it dictates the next safe step in care. Let's move on to section 3, evaluating local diseases and pushing beyond the surface level.
This whole framework demands a simultaneous 2-level assessment. You can't just stare at the lesion, but you also can't just ask about the patient's general mood. You literally have to do both. Level 1 is the objective physical examination of the lesion itself. Where is it anatomically? What's its morphology, its color, its borders? Level 2 is the whole patient's systemic context. How is their general vitality? What are their comorbidities? What's their mental state? In this philosophy, the local issue does not exist in a vacuum apart from the whole organism. And Hahnemann makes a really critical distinction here regarding the etiology or the root cause of this local disease. He's very clear. A traumatic or mechanical injury, like say a sprained ankle, a severe burn, or getting a splinter, that requires straightforward mechanical, surgical, or first aid care, obviously. However, a dynamic etiology, like a spontaneously arising inflammatory rash or some kind of chronic arthritic node, that originates internally. Because of that, it requires an internal constitutional remedy, not just external management.
Which leads us perfectly into Section 4, the danger of suppression and the pitfalls of relying on topical treatments.
So this is a major philosophical warning from the source text. If you use a super strong topical cream or chemical cautery to just wipe out an external lesion, you are effectively destroying the primary visible barometer of the internal disease. It creates this totally false reassurance. The patient thinks, awesome, I'm cured because the rash is gone. But the classical view argues that the underlying internal pathology is actually still there, progressing silently and potentially driving the disease even deeper into vital organs.
Because of this dynamic, when a lesion vanishes, a practitioner cannot just automatically assume a holistic cure has occurred. Sure, a disappearing lesion could mean a natural healing process from the inside out, which is the dream scenario, but it could also just be temporary palliation or even just the natural fluctuating course of the disease itself. The practitioner has to constantly monitor the patient's overall systemic vitality, their sleep, their emotional well-being, just to verify if true deep healing is actually taking place.
Finally, Section 5, red flags and referrals. This is all about setting absolute clinical safety boundaries. The absolutely crucial takeaway here is that philosophical frameworks must never, ever replace mandatory diagnostic biopsies or emergency medical interventions. If a practitioner sees a pigmented lesion with irregular borders, or a non-healing ulcer that bleeds easily, or a rapidly spreading infection accompanied by a fever, those are massive, flashing red flags. The mandatory action is immediate referral to a specialist, an oncologist or an ER. Delaying that kind of care for unmonitored alternative therapy isn't just a mistake, it's considered clinical negligence.
Let's ground this with a concrete example from our source text, the clinical case of the rubber tapper. We've got a 58-year-old man who comes in with exactly one complaint, a non-healing sore on his hand that's bugging him while he gardens. Now, if you only look at the hand, you might just hand him a skin ointment and send him on his way. But by taking the time to investigate that hidden totality, the practitioner uncovers 5 kilos of unintended weight loss, drenching night sweats, and a fixed axillary lymph node. Suddenly, we aren't looking at a simple skin sore anymore. This is a high-risk red flag for a serious malignancy, requiring an urgent oncology referral.
So if you take just one thing away from this entire explainer today, let it be this. Look beyond what is most visible. That isolated, screaming symptom is your anchor, for sure, but it is not the boundary of your investigation. The classical method demands that you act as a systemic detective. You have to seek out the hidden totality to treat the whole patient, the whole shebang, not just the localized part, while always maintaining strict clinical safety. I'm going to leave you with this final provocative thought to chew on. In our super fast-paced world of quick fixes and instant topical creams, does modern medicine focus too heavily on just erasing the visible symptom at the cost of understanding the whole patient? Thank you so much for joining me on this explainer today, and keep asking those deep questions.